Okay, thank you, Brent, and thank you for the organizing committee for inviting me to speak. For those of you with unfortunate travel plans that you're left behind here for the last talk, hopefully we'll learn something. So, as a therapy medical physicist for my career, I entered my last job, and when the interview was going real well, and then sort of toward the end they said, "Oh, by the way, we'd also like you to be the RSO." I said, "Well, I don't know. I've never done that before. I'm not sure I want to," and quite frankly, I almost turned the job down because of that. So there's this book here by Robert Heinlein, and does anybody know what grok means? No? Nobody's read the book? Pardon me? So it basically means to know intuitively or to know completely. And I'm going to suggest, as a therapy medical physicist, this will never happen in radiation safety. So you're not going to know this stuff intuitively. You're going to have to really dig into it and understand it. So I have no conflicts of interest. And here are our learning objectives for today. So basically, we want to go over some of the common imaging procedures and what are the expected ranges of exposure, and then discuss strategies for reduction of that exposure. And that's really to patients and staff. And then finally, we'll go in and discuss some real-life scenarios that illustrate the range of consults that you might encounter. And these are things that are going to take you kind of outside of your realm a little bit. Okay. So again, I come from radiation oncology, and we work with really, really massive doses, and you might be a little cavalier in encountering diagnostic imaging and think, these doses, I mean, how high can they really be? Well, the answer is they can be very high. So these are the kinds of injuries that you might encounter if you don't use proper safety techniques in diagnostic imaging. So when you enter this world of radiation safety, and is there anybody here that is a therapy physicist and also an RSO? I see a couple hands. Did any of you have specific training in radiation safety prior to becoming the RSO? So these are some of the things, again, you're going to have to jump in and learn. So who gives you the authority to do this? You've got the title, you're the radiation safety officer. And what does that really mean in the world of diagnostic imaging? Who are your customers, so to speak? What kind of procedures do they do? What are the ranges of dose? What are the potential side effects? And perhaps more importantly, you have to get in and understand the workflow of the department. To understand how you might implement a safety barrier, you have to know what's going on. So here's the authority. It comes, right from the federal regulations. And, the licensee shall provide the radiation safety officer sufficient authority, organizational freedom, time and resources, and management prerogative too. And you can see the things there. And basically what this means is you need to have administrative support for what you're doing. You have to have some kind of stick to back you up when you go to a physician and say, you can't do that. Most of the time a surgeon or somebody is just going to brush you off and say, get out of my OR. But so you need to understand you do have real authority to implement radiation safety. So let's get back to who are your customers? Now, first and foremost, we're all in this because of patients. This is medical use of radiation, and kind of my one sentence summation of what we do as medical physicists is that we ensure the safe and effective use of radiation in medicine. So we need to make sure that the patients are safe. We need to ensure that the family members of the patients are safe. The general public, that's kind of our primary concern, but we're also concerned with protecting the staff and physicians. one thing I emphasize here is you have to be out in the clinic, meeting your customers, and again, understanding their workflows, what are their concerns. If you hide in your office, you're not going to be able to do an effective job in radiation safety. So communication is really what it comes down to. You need to be able to communicate with patients. So there's a nice symposium, a little shameless plug here, at the annual meeting. I don't know if any of you will be there, given that you're here, but I think it'll be in the virtual library afterwards. So this will be a resource that you can use in the future. So one thing, and this was an interesting study, are patients really aware of the risk? And it turns out in this study anyway, on average about 70% or 7% reported knowing that there was an increased risk of cancer from ionizing radiation. That's shockingly small to me. Based on the comments I've gotten over the years, I would have thought that number would have been a lot higher. So it's our duty really then to educate the patients. And what it comes down to is informed consent. They are going to receive some sort of procedure in which radiation is used, and they need to understand the risks. So, a lot of times when you're talking to them, and is anybody Greek here? Oh, can somebody translate? Okay. But a lot of times this is what the patient hears when you're talking, and you're going through all these things of millirems, sieverts, microsieverts, whatever. I have no idea if this text applies to radiation safety really, but it's the only Greek phrase I could find online quickly. So here's some guidance from the Image Wisely campaign that Steve mentioned earlier. And the Image Wisely resources are great. They have a lot of information out there on how you can talk to patients, how you convey technical information, different tips in speaking with family members or physicians or what have you. So I would suggest you go to that website and check out their tools. But here, they're just some of the basics. Avoid technical medical jargon. You have to, in general, they say speak at a 5th grade level on average. Translate it into everyday language, so something they can compare it to. Use short sentences to convey a single point. You don't want to have this massive paragraph that has 5 or 6 pieces of information in there. And format it in a way that it makes it obvious what you're trying to convey. So what are the main things you have to communicate with the staff? A big part of it is, the proper use of the badge. And Steve mentioned earlier, you give a badge to somebody if you think they might exceed 10% of the allowable limit. And in my experience, it's worse to give somebody a badge if they're not going to use it properly than to not give it to them. So you really have to establish they reasonably need a badge. Because if the state inspector comes in and finds a whole box of unopened badges, they're going to have a discussion with you. So be careful about just volunteering to give everybody a badge. You have to wear them in the right location. We have, New York is a little funny. I don't know if this is true in the rest of the country, but only physicians can use EDE 1 and 2 badge systems. The rest of the staff cannot. But physicians often will mix up which badge goes where, and then you get a funny reading, and again, you get a phone call. But use the proper shielding. There are other kinds of shielding, whether they be drapes or mobile shields or what have you. Now, one thing that I've heard a lot of people talk about is being careful in using, for instance, drapes. you don't want anything that's going to impede the image and therefore drive the exposure up and reduce image quality. So be careful to use the shields properly, not only in the safety aspect, excuse me, but also in the imaging aspect. And that goes back to understanding the workflow again. Using the proper techniques. So, you know, if you're imaging a pediatric patient, going back again to the Image Wisely or Image Gently campaigns, make sure you're using pediatric techniques. Okay, so again, with the physicians, they have to wear the badges. We don't want to have that conversation with the state. Make sure they're wearing them in the right location, and again, use of shielding. So what kind of range of doses can you expect? This is some information from one publication. You probably can't see that very well, so blow it up a little bit. And you know, you can see right here at the top, you have nuclear stress imaging, and it's both a relatively high exposure per exam and a high frequency. So it contributes a high percentage of the total exposure to patients. Now, if you add up all the CT procedures here, it would add up to about 50%, but each individual one is less than the nuclear imaging. So you can see there are some exams that have a lot of exposure per exam, but they're not done very frequently, so the overall percentage is low. So these are the kinds of exposures you're going to encounter. You know, the three areas that you're going to see the most dose are nuclear imaging, CT, and interventional radiology. Okay. The other thing is sometimes you'll get a patient with a unique set of diagnosis, and they're going to have 5 CTs within a year, 10 CTs maybe. And so you have to really understand the effect to the patient, you know, with multiple exposures. And this is perhaps something the therapy background helps, because we are used to fractionation, so we understand the concept of, you know, the impact of multiple exposures versus a single exposure. So, and that's just basic science that we probably all learned in graduate school. But here's one resource that's also good. If you go to the IAEA website, they have this RPOP area that has a lot of good resources. Again, that's another one I would recommend. So the late effects of exposure, and the two that most people are going to focus on are really cancer and skin burns. Those are at least the questions I've gotten. I've never had anybody actually, not a patient anyway, ask about cataracts or sterility, but those are potential side effects. Okay, so skin injury, you know, the onset of an effect versus the timing is demonstrated in this reference, and you can see sort of the secondary ulceration that is really going to drive, you know, your more advanced or complicated side effects happen somewhere in the 10-week time frame. So it's not going to be immediately obvious that you're going to have an acute injury. So that's why, you know, Steve mentioned, you know, of course, using those dose metrics. So you either have an air kerma metric or a dose area product metric or excuse me, some other kind of metric that you use to kind of flag, hey, we need to watch out for this patient. And then you're going to have to do some follow-up, you know, phone calls, check on them, you know, maybe a phone call to the primary care physician to let them know, you know, what they might expect. So So the induction of cancer, the most common types, or the most radiosensitive areas of the body are breast, thyroid, and the bone marrow. So you have the induction of leukemia. And the research that I've done, the lowest observed cancer induction for a single exposure is about 10 centigrade. And of course, we all have that argument of how do we extrapolate from a high dose down to a low dose. And that would be a whole other topic to go through those arguments. So I'm going to leave those behind. But one thing you can say really is that there's some non-zero chance of cancer induction at low doses. So how do we balance that risk with image quality? And again, this is from IAEA. They kind of frame it nicely in terms of, improving the quality of medical images always means increasing the radiation dose. You don't magically get better imaging just, by flicking a switch or whatever. Although, you may talk about different reconstruction algorithms or something like that. It allows you to get better image quality at a lower dose. But in general, better quality usually means more dose. So, and the object of medical imaging is not to deliver the perfect image, but one that is diagnostically adequate for the specific health problem. So if you don't need a certain resolution, which is going to drive the dose up, don't use it. And there's other things like frame rate and fluoro, and you could go on and list a lot of ways to reduce dose. Okay. But too low of a radiation dose could be as bad as too high, as the image, you get unusable images. So that's the worst thing you can have, is you've done a procedure and you've gained no information that's going to benefit the patient. That's probably a worse outcome than some non-zero but very small probability of an injury. So again, the website's listed down here. So, dose reduction is really a large focus of what we do. How do we keep those doses low while maintaining image quality? So the FDA has a relatively recent campaign to reduce unnecessary dose and radiation in medical imaging. Okay, so this is right from their webpage. 2 principles of radiation protection developed by the Joint International Commission on Radiation Protection is justification and dose optimization. So there's those 2 things, is this exam needed, the justification, and then once you've justified it, how do you deliver the lowest possible dose while still obtaining the diagnostic information? All right, that effort really takes the cooperation of everybody involved. You're going to have the physicians, the physicists, and the technologists all working together to ensure the proper delivery of that procedure. And this comes from the Image Wisely webpage, as you can see there. I can't emphasize enough this multidisciplinary approach. And again, getting back into being seen in the clinic, getting out there, working with all of the stakeholders to ensure that the dose is optimized. So talking about the justification, the ACR has these appropriateness criteria, and you can see the webpage there, and they get to be pretty detailed. This is an example of one from the Image Wisely, but they quote the ACR here. So this is a patient with acute abdominal pain and fever, presenting with non-localized abdominal pain and no recent operation. So you can see they categorize each of the possibilities based on how much radiation. So, it's kind of like a 1 to 5 star rating system with 4 little radiation symbols being a relatively high dose. And you can see, the other ones with 3 symbols. So this is what they've deemed as, the rating system, 1 being least appropriate and 9 being the most appropriate what they think would be the most appropriate exam to obtain the right information for this patient. Okay. So let's compare that same presentation, but this time the patient is pregnant. All right, so now with taking that into consideration, you can see how it's totally flipped as to what is the most appropriate exam. Okay, so you really have to establish this with your physicians, make them understand maybe it's not always the best exam to do, a CT. All right, and the other factor playing into that is the referring physician may have no idea about image quality or radiation dose or whatever, but they might just get on the phone and say, I want my patient to have a CT. And then you have to have that discussion. Well, at least hopefully the radiologist will have that discussion. Okay, another factor in ensuring that the proper technique is used is a regular review of your CT protocols. And I really wish the vendors made this easier. There should be a simple way to export those protocols, review them, compare them against a baseline file, and say, okay, nothing's changed. Does anybody have a problem with that? Getting that information out in an easy format? No? So that, maybe that's something the APM can help drive forward, is to make that kind of information easily available. Because this can be a very time-consuming procedure, and with the new requirements that this is done on a regular basis, so you need to find an easy way to do this. And there's actually an APM medical physics practice guideline on this topic, which you can see the reference here. So I would suggest that you read that. So what can you actively do to reduce dose? Well, in CT, it's the analogous thing to collimation. Reduce the scan volume. If you don't need to scan the entire body, don't scan the entire body. Use smaller KV for smaller patients. Appropriate filters. Larger pitch if possible. Shorter rotation times, and then the dose modulation. If you're going through varying path lengths over the exam, you can use that dose modulation to keep the dose lower in areas where you don't need the extra tube current. So again, back to the Image Wisely campaign, dose reduction in fluoro, they published a series of checklists that you can use to help keep the dose low, and they break it down into pre-procedure things that you can do. And you can see all this list here, and it's kind of common sense things, but again, if you use a checklist, you're more likely to actually do something rather than just off the top of your head trying to remember to do things. We have struggled with this in our institution, and we've tried to implement some of this into their timeout procedure, but they say, well, the timeout's already too long, it's going to end up kind of, reducing the effectiveness if you have this massive checklist that you have to go through prior to each procedure. But, I would suggest at least educating the staff and make sure that they understand that these are the kind of things that you should do prior to the exam, and in particular, determine if the patient is pregnant. Because as you saw earlier, that could impact the fact that is this even the right exam to do for that patient. And it's explicitly said here, maybe consider ultrasound. Are we going to get adequate information through that exam and not exposing the patient to radiation? During the procedure, you can do these things, and they're pretty much the same kind of things, using proper collimation, use last image hold. You'd be surprised at how many physicians still to this day will just keep their foot on the pedal while they're staring at the screen. Just a gentle reminder, hey, you can take your foot off the pedal. and that'll save a lot of dose. You know, minimize overlap of fields is sometimes a little bit difficult. You know, if they really need a certain projection, for instance, doing an interventional procedure, if that's the right projection that they need, you know, you don't want to compromise the effectiveness of the procedure, but again, remind them, hey, maybe you could angle a little bit differently and make sure that those projections don't overlap. You know, unnecessary personnel should be behind shields or outside the room. And the last one there, really enforce your dose metrics. You know, somebody needs to be charged with letting the physician know, hey, we've reached dose metric 1. We've reached dose metric 2. Stop and take some time and think, okay, can we delay the procedure? And there may or may not be a medical reason to do that, but the bottom line is pay attention to those dose matrix during the procedure, not just afterwards where you're required to excuse me, note it in the patient's record, but actively monitor it during the procedure. And then post-procedure, review and record the dose metrics. And if those dose metrics are exceeded, you have to have a policy in place that says what you're going to do. Is it going to be a follow-up call from the nurse in a week, follow-up call by a physician in a month? You know, whatever that protocol is that you have to have some way to note that you've implemented that protocol and actually done it. So in nuclear medicine, you know, you can do some different things. You can ensure you're using the proper radiopharmaceutical. The quantity that you inject, obviously you want to obtain a proper image in a reasonable amount of time. You don't want to have the patient sitting on the table for an entire day. Obviously that's going to have image quality impacts as well. Using the proper collimator. You know, if you use a collimator with a higher resolution unnecessarily, which drives up either the time needed or the injected activity, you know, make sure you're using that right, and also use the proper image filters. And a lot of this is really just education, keeping these kind of things fresh in the minds of the people that are performing the procedures. So I'd like to spend actually most of the time going over some real-life scenarios. And so I'm going to need some volunteers from the audience who are willing to provide a medical physics consult for radiation safety. So I guess we could call this the Dose is Right game show. So do I have any volunteers from the audience who would like to deliver a radiation safety consult? Anybody? I'll have to pick on Bruce. All right, so here's the situation. You're the only physicist left in the building. It's about 6 o'clock at night. You get a phone call from the emergency department. They say, we've got a pregnant patient here. She's been in a car crash. We'd like to do a C-spine x-ray, but the patient is refusing because of the radiation concern. So can you come over and talk to the patient? So they say, yeah, I'm going to go over and talk to the patient. You get in the room, and the emergency room physician is there and kind of badgering the patient, hey, we need to do this exam. You know, the exposure is really not a problem. And besides, if you lose the baby, you can always get pregnant again. So the patient bursts into tears. The doctor says, walks out of the room. Can't take it anymore. And that's when the husband says to you, we've been trying to get pregnant for 5 years. This is the first time we've made it to the 2nd month. So, okay, what do you do, Bruce?
Of course, we're making the assumption that I have even a half a sense of being unqualified for this, which may or may not be true. I think there are two things. The first one is to essentially talk to the patient a little bit about risk-benefit. What is the risk from medical of this exam, which is probably pretty small, although you've indicated that one of the things is to know is what part of the term she's in. Because clearly, first term is a little more hard, but in truth is, it really doesn't matter. The risk is very, very small compared to the risk of her having significant injury that could cause her to perhaps lose the baby because of that more than because of the exam. So my counseling would be based on being able to show her what the risk is. Now, you have to have the metrics to say, it's the equivalent of driving your car 20 miles or something that she can relate to, and not being able to talk about the biological effect and the dose, as we've noted, because that means nothing to them. So that would be where I would be going, assuming that I had that information at my fingertips to be able to make a legitimate risk-benefit comparison for her.
Okay, great. I see we have some people that might have some additional information.
So I'm going to make a comment here because I actually feel very, very strongly about this. And in terms of what information we're giving to patients, especially when it comes to pregnant patients. And I'm going to put out the argument that we have to be very, very careful about what we say to a pregnant patient. The vast majority of the time, they are much more concerned than what is warranted. But it's their pregnancy, not mine. And I want to help them. I tell every single patient that I talk to that I fully respect their right to make whatever decision is best for them and for their family, but that my goal is to help make that an informed decision. But I will also share with you that a couple of years ago, I was having a discussion with Jerry White about risks and the overblown, sometimes vastly overblown perceived risk for pregnant patients undergoing imaging exams. And his comment to me is, if you have a pregnant patient come into your hospital, why would you give them substandard care by suggesting that they not have a medically indicated imaging study? And the vast majority of the time, there are very few exceptions to this, but the vast majority of the time, the risk to the fetus is so much lower than the risk associated with everything else during the course of the pregnancy. And I really strongly back that up, and I think that he summarized it really well. So that's my comment.
Great, thank you. Mahesh?
Just adding to the same point, the rule of thumb I use for any of these cases is, if a pregnant patient get any type of X-ray procedure, if the abdomen and pelvis is not directly in the primary beam, you should not even think about anything against it, because the risk is so minimal, nothing there. That's one thing. That's what I tell our residents to keep in the back of the mind. If it is an abdominal and pelvic, then we can help them to assess it. Even then, in all these years of my experience, we do a lot of these patients with the pregnant. Every week we get some. I'm okay with that. As long as the clinical indication is strong, the risk is minuscule. But we have to stress that as a medical physicist, because there is a nice paper in radiographic telling like the risk associated with pregnancy plus the risk associated with pregnancy plus any radiation exposure is so small. 99.9 times of the time it's nothing there. So we need to, because our physician colleagues sometimes they are overly scared about radiation, and sometimes they are unnecessarily scaring the patients.
Yeah, Jessica.
So I second Mahesh, and just wanted to share with the group two different fetal dose calculations that I had to perform as RSO. One was a patient in her first trimester who was in a terrible car accident, lots of trauma, lots of CTs. It turned out she was driving and she was intoxicated. And I think that in that case, other life risks, to Mahesh's point, were much greater concern than, the exposure, even with a primary CT of the abdomen. And the other one, this is an interesting one that the RSO may find themselves in. An 11-year-old girl came in with abdominal pain, and received a radiograph and was 7 months pregnant. Not a good conversation to have.
Right.
Yeah.
Okay. Sergey, you have a comment?
Just from the point of patient whose interest we defend, I would talk to physician first, even before starting conversation with patient, and suggest, well, kind of politely challenge the need for X-ray. I don't know what the exact situation is. Or suggest that maybe if MRI can replace an X-ray, and then all this conversation with the patient would be unnecessary then.
Yep. Okay. So one thing to note, I'm taking notes for that, and we're going to post this on the website after, so everybody will be able to see it. So I'm going to suggest that those were all great comments, but there's a couple things missing. The first thing you need to do, I think, is apologize for the comment. You know, clearly that was an inappropriate comment from the physician. And we're part of the clinical team, so we have to do what is called service recovery. You've just really, really ticked off the husband, and you've watched the patient be shattered by that comment. So for their mental well-being, you need to get in there and apologize for that comment, acknowledge that their concern is valid. It's a very reasonable thing for you to be concerned about radiation exposure to your baby. So acknowledge that the concern is real and valid. You know, and then maybe establish some empathy. You know, I have a friend who's in the same situation, who's had trouble conceiving. I understand it can be difficult, and this is a very important decision for you. Okay? And the other thing that I would do is mentioned earlier, but I would say, yes, I would recommend you having this exam, but I understand it's your choice. And you know, whatever choice you make is reasonable. Okay? Or maybe it's not quite reasonable, but it's your choice. And then I would end with, here's my contact information. If you need any other questions answered later, if you think of something later, please feel free to contact me. Again, you're a medical physicist, you're part of the clinical team, you know, you need to establish that relationship. So those are some additional things that I would mention. Okay, so next situation. Any volunteers? No? We scared everybody? All right, I'll explain the situation and then maybe somebody will step forward. All right, so you're in your office, you get a phone call from the secretary in radiology, and she says, I have the father of a patient on the line, and he wants to get some answers about his son having a CT of the head. Can you talk to him? Okay, sure, I'll talk to him. So the guy gets on the phone, and he says, look, do you people know what you're doing? I have had 3 different answers from 3 different people on what the effect of the CT is going to have on my child. The physician told me, it's no big deal, don't worry about it. Then the nurse told me, oh my God, that exposure is so high, I would never let my child have a CT. And then the CT tech told me, it's like a couple of chest x-rays, it's no big deal. So which one of these people is right, and what can I expect from this exam? So what are your first thoughts? Rebecca? I'll give time to think as you're walking. Yeah. But again, if you're the RSO, these are the kind of things that are going to come up, and there may be a little outside of your day-to-day activities. So you have to be able to expect this kind of thing.
So I've had this exact conversation many, many, many times with patients or their families. And the first thing that I always do is say, I apologize that you've had so many difficulties and that you've gotten such mixed information. Actually, it is the honest truth that our institution, that we're trying to improve that communication, and so I relay that to them. I said, I know it's far from perfect. But and maybe this is wrong and other people have other input, but I kind of say, you know what, our technologists and nursing staff are very, very good at what they do, but this isn't their area of expertise. And I do kind of premise it with that. And I feel like I have to establish some sort of, I don't know what the right word is for it.
Integrity?
But, excuse me?
Integrity, or at least some file form that you
Something,
that
and
you've
I'm not,
got
you
some
know, I don't want to
back
throw
in.
them under the bus, but you do have to establish that,
Some type of
why are they
knowledge,
going to trust
expertise.
you rather than the CT tech? Yeah, credibility, thank you.
Yeah,
And so that's kind of the approach that I've taken, and the physician issue is a little bit harder, and I've actually talked about this with several radiologists, because one thing that I get a lot from people is people saying, my physician told me that I've reached my lifetime maximum radiation exposure, I can never again have a fluoro procedure.
Yeah.
Now, whether this was lost in translation is kind of, whether the physician actually said this or not, I have no idea. But I've talked about this with radiologists, and I'm like, you know what, I'm not going to throw the physicians under the bus, and their response is always, go ahead and do it, because you have to give the patient correct information. Now again, I think that other people may disagree with that, and I kind of still have mixed feelings about saying something like that about a colleague, but that's kind of been my experience.
Yeah.
Just to add to what she already said. First thing is, these scenarios are the one is give us a good opportunity for establishing a medical physicist role in the clinic. Hats down, because once you start answering and readily available to answer these questions, in our clinic what we have done is, our radiologists don't even talk about radiation dose to the patient. If they have a question, they direct to medical physicist. And that happens over a period of time once they have trust in us. And it's the same thing with the technologists and the nurses. I discourage them to give numbers and also talk about radiation dose. Giving numbers to the patient is waste of time, because they will Google to a website, and that can lead to a lot of other things, misinformation. I would rather have used these type of situation to establish a rapport in the clinic, because that's not only establish our value, but we actually are doing a service. So that's one thing. Talking to this scenario, I would right off the back, again, establish what's my background is, where is my expertise, and then tell, here is the facts, what we believe in it. Again, in diagnostic imaging doses, we cannot exactly tell the risk, because there is a lot of uncertainties. But however, what I would really like is, these scenarios are the one where establishing the physicist role highly critical in the departments. And I would definitely not hesitate any one of us to utilize this situation to establish ourselves.
Yeah, thank you.
As by way of introduction, it's probably important to remember that I work in Boulder, Colorado. We have a lot of really intelligent people that know how to do, well, they don't know how to do web research. They have wide access to web stuff. And they think they can learn everything. They're not very good at that. So we have a lot of really, we call them Boulder Crunchies, and because they're all sort of granola and holistic and are terrified of radiation. I get these questions all the time. I can get several a day from patients. What I have, on top of what everybody else has said, one of the things that I have found works the best boils down to the mom test. When I tell them, in this particular situation, I would have my child in that scanner as soon as possible. I would not be worried about the radiation dose for my own kid. That goes a long way to them. It helps build the credibility. You're addressing it to something. You're saying it's as important to you as it is to them, and you're saying that's not a concern. And that really helps a lot when you relate it to what you would do with your own family.
Right. And it gets back to establishing empathy with the patient or their family member.
To amplify a little bit what Doug said, a number of years ago, I spoke to a set of parents, and I started off the conversation by simply saying to them, I'm not going to tell you the risk is zero, and I'm not going to tell you it's not something to be concerned about. The husband looked at the wife, and he simply said, thank God we finally found somebody that would be honest with us.
Good point.
It's all about your credibility.
I wanted to add something about a risk metric that I found helpful in explaining to patients. It's fairly easy to explain the risk of cosmic radiation. The atmosphere is protecting us, our body is built for that. And given that I live on sea level, I can say the amount that you get with this study is the equivalent of taking a 4-week vacation in Boulder, Colorado at altitude. And a lot of time, this is super helpful to put it in perspective. Would you be worried to go for 4 weeks to Colorado if you're pregnant? That gives me a really good grasp of what the risk is. And just wanted to float that out there.
Yeah, thank you. Okay, any other comments on that scenario? All right, so let's see if all my notes are hit here. The only other thing I had down here was to emphasize to the parent that we are aware that your child is a child, and we will use the appropriate techniques based on, a pediatric case. All right. So here's one that came up recently in our institution. So I got a phone call from one of the imaging technologists who said, I think we need to delay all cardiac catheterizations 1 day if the patient has had a nuclear stress test. So how do you respond to that? So he's basically saying, I don't need the exposure coming from the patient while I'm in the room with them for several hours. Yeah. Well, that's eventually what we did. We did it in a somewhat polite way with a very elaborate policy and procedure. So basically, again, you have to say, I appreciate your concern. I understand you have a concern. But why do you think the patient had the stress test in the first place? It was to establish if there was some sort of cardiac issue, right? Well, why do you think they scheduled a cardiac cath? It's because they found some sort of cardiac issue. So if you think the exposure you're going to receive during that several-hour procedure, the risk to you outweighs the risk to this person having a really serious cardiac event over the next 24 hours, do you think that's a reasonable trade-off in risk? Your negligible risk for the very real clinical risk to that patient of having a cardiac event at some point in time. That's the whole reason they had the test in the first place, was to establish if there was some sort of deficit, and the cardiac cath is the fix of that deficit. So obviously, we need to proceed with that. And the medical necessity trumps your radiation safety concern, although I acknowledge it's a valid concern. But then we did the math for them and said, okay, your exposure, even if you're right at table side for the entire procedure, is probably about 3 millirem, if you're there the whole time. So you understand what the annual limit is, and you also understand that you're going to get as much, if not more, exposure from the fluoro than you are from the patient. So, let's put the risks in balance, and we're going to do the procedure. So, the medical necessity trumps radiation safety concerns in terms of if it's a clear impact on the patient medically. And that's a point that has been brought up earlier in reference to the CT scans. Even if I'm sorry, is there a comment? Okay. Well, actually, yes, as a radiation worker, that's a risk you have accepted. And that's why you have a higher limit than the general public. So yes, you've been paid to acknowledge that risk and therefore are considered a radiation worker. All right, so another one.
I've got a little comment. Then you
Okay.
might actually want to look at their badge report from the last quarter. you know,
Yeah, that's a good idea. Review history. So at our institution, I've been the RSO for 9 years, and we have never had anyone exceed 20% of the annual limit over an entire year. We've had quarters where they're above that, but never for an entire year. Any other comments? No, I'll move on to the next one. So I got a phone call actually from the CEO of the hospital. And he said, you know, I'm looking at the budget and we're spending a lot of money on these things called rad pads. And, you know, I want to get rid of them. But the doctor is refusing. The doctor says, I need to have this safety device or I won't do the procedure. So can you tell me, is it worth it using these devices? So how do you respond to that? Yeah, you can't laugh at him. It's the CEO. Yeah. So that's exactly what I did. Is I went out and did a literature search on it, and of course the vendor said it's an 80 to 100% reduction in exposure through the use of this device. I thought, well, that's a pretty outlandish claim. You know, really? I mean, I understand under table tube and you know all this stuff and direction of scatter, but that seems a little bit far-fetched that it would be that high. So I actually did my own phantom measurements. You know, we had coming from the therapy environment, we had a rando phantom, and I put legs on it so that we could, adequately mimic the femoral access. I had the tech with me, and we positioned the tube like the tube would normally be positioned for 2 projections, measured the exposure at different points, and I documented about a 40% reduction, which was higher than I expected, but still not quite as high as what the vendor had claimed. And then I went back and looked at the exposure history of the physicians for the 3 years prior to implementing the rad pads and the 3 years after. And indeed, their exposures dropped significantly after implementation of the rad pads. But in discussing this with some colleagues earlier, a good point was I should have verified maybe we got new equipment at that same time, and that was the reason for the dose reduction. But the fact remained there was a significant dose reduction. But the bottom line is, how do you equate a reduction in exposure to staff to dollars? $100 per procedure, or whatever it is, $75, to let's just call it a 40% reduction in exposure. That's what the CEO wants to know. Is it worth spending this money to reduce the exposure by 40%? He said, I'll accept your numbers.
So we've had this come up specifically, and it's a related thing with lead-lined caps for interventionalists. And I actually got this email last week, not from the CEO of the hospital, but from purchasing, actually. And in that case, I prepared because I'd actually already written something that kind of talks about some of these things. With the lead caps, the bottom line in my mind is there is no benefit to the interventionalist except for the added peace of mind. I am not going to sit there and have an ongoing argument with an interventionalist if because some of these folks, they are just convinced. We had our vendor rep come in and tell our interventionalists that they know of a physician in California who's dying of a radiation-induced brain tumor, and that the only cause of glioblastomas is radiation exposure. I kid you not. And they eat this stuff up, and it just instills the fear of God, and they're just terrified now. And so I try to approach it as in that case, there's no real harm done. Now, in the case of the rad pads or things where you're wrapping patients with lead, there is a potential of risk to the patient and to staff in terms of increasing exposure. With the lead caps, if they want to pay the money for the peace of mind, then I don't really feel like it's my job to say that they absolutely shouldn't.
Yeah, and so my current course of action is I'm investigating if there are alternative solutions, and is there a reusable option rather than it's a disposable option? Because in general, just being environmentally conscious, I don't like the idea of just throwing stuff in the trash all the time. But there's some other avenues to look at. All right. Any other comments on that one?
Hey, Dan, would any type of bedside shield didn't work? You know, a drop-down shield?
Yeah, they use shields as well, but you know, they're not as effective, I guess, at blocking the scatter coming from the patient.
I just want to make a quick comment. Someone shared with me yesterday that there is an article in JACC that Beth Shula had something to do with that looks at what the actual radiation dose reduction could be with these different types of devices. And I haven't read the whole thing, but I'm just making you aware of it. In part of the abstract, they are claiming for the results section, the radioabsorbent surgical cap reduced brain dose by only 3.3%. That's in JACC from March of this year. So thank you, Beth. I haven't seen her if she's here, but I'm happy to share it with anybody as well.
All right, thank you. And we'll put that in the notes and post it online. Yep, Melissa?
Dan, you asked if there was another alternative system. We, unfortunately, one of the hospitals we work with, their chief interventional radiologist, who was also chief of radiology, is one that died of leukemia. And at that point, they got enough donations that they have actually installed the zero gravity workstation, protection systems in every one of the interventional rooms and all the cath labs. And the radiation exposure dose is less than 30% of what it was prior to the installation of those systems. They are about 200 grand a piece, I understand. So it is an expensive system, but it's there, it's permanent, and they all use them. And so you don't have to do any of the, you don't have to keep buying the rad pads or anything.
Okay, and that's called zero gravity?
Mm-hmm.
Okay.
Or zero exposure or zero, I think it's zero exposure. Yeah. But there are other options out there rather than the rad pads.
Okay. All right, any other comments on that one? If not, I think we have time for one more. All right. In this case, the local newspaper calls and says, I'd like to talk to an expert about radiation exposure to diagnostic imaging patients. And, I was given your name. So what can you tell me about medical radiation exposure? Anybody want to jump in? All right, so I'll go back to something Mahesh said earlier, this is the perfect opportunity to identify what a medical physicist does and their important role in reducing exposure to patients and staff and family members and general public, okay? So that's the first thing I would lead with, is what do we do and how do we impact that exposure? Right. Doug, you have a comment?
No, I just like wandering up to the microphone every once in a while. Absolutely, establishing who medical physicists are is important. I have run into this one, and one of my first thoughts is taking this as an opportunity to debunk a lot of the stuff that's out there already. To say that most of the diagnostic exposure stuff that's been published is abusing a single table in a report, and even within the report they say don't use a table the way it's being used, and really making the point that these risk estimates are not real, they are purely hypothetical, and they have never been observed in human populations. And start with that and then explain levels and comparisons to other risks and factor radiation and stuff like that. But I always start by debunking the abuse of the beer report, because that has blown everything way out of proportion.
Yeah, yeah, and that goes back to earlier what I said about, you know, the lowest observable dose at which any effects have been seen are still relatively high doses, well beyond what we would see. Jessica?
So I completely agree about establishing yourself in the clinic as a resource, but I also think there's a balance. If you start to get into these consults, it could get to the situation where the physician defers everything to you all the time and doesn't take any responsibility. I had, you know, a chief of radiology department giving my personal cell phone number to patients to say, hey, you know, can you answer all of these questions? So, you know, while it is good to be a resource and be available, I think you have to set your boundaries, and it's an approach. You need to go at it several ways, and I think there's an education piece for the physicians, right? I mean, it's so hard to get every ED physician and every referring physician like on the bus, all, you know, kind of speaking the same language, but you have to try, at least with maybe, you know, some of the key individuals, so it doesn't get abused.
That's a good point. Comment?
Hi, my actually I came across one situation like yours, this question, and one is my previous professor, and he asked me one day, he asked me one thing. He said it's one of his friend, and he discussed with him, and how about how much chance that the cell phone can cause a brain tumor. Yeah, I saw some fake news. They might be in some media. They talking about the cell phone. The cell phone can cause brain tumor. Then my professor asked me to do detailed calculation. He's an excellent atomic physicist. Then I have to pull out all the quantum mechanics, electron dynamics book, doing the energy calculation and search some cell phone signal. Yeah. After I calculated, I showed him. I know the answer actually before I calculation, but I have to do some calculation for him. Showed him, oh, don't worry. And the cell phone at this moment, still no any evidence, clinical evidence can induce the brain tumor. Yeah, that's it. This is what I want to share with you.
Yeah, that's an interesting question. All right. Are there any general questions?
I think all these scenarios were great questions to have this discussion about, and I appreciate you tabulating everything and providing it. Since there will be a venue in the PC Symposium at the annual meeting, may I suggest that you include some scenarios where there really is an issue, where you calculate, you estimate fetal dose with some reasonable certainty to be in the 50 to 75 milligray, you know, region, which is above the, you know, published threshold. How do you have that conversation? Do you defer it to a physician, you know, those kinds of things? Because I think you can hear from the passion in this room that we deal with the stupid questions all the time. Well, they're not stupid, but, you know, like we got that for the most part. Yeah, we should use some more empathy, and there's some tips to improve that. But I think when you get that really scary, like real scenario, how do you handle that would be really helpful for our members. Thanks.
Thank you.
We've addressed a lot of our dose issues with diagnostic exams, even for therapy, almost always in a negative fashion, which is it's no more than this, or you don't get any harm from it. If we flip it around, and I think I take this from Lou Wagner, and go positive in terms of we're giving you the highest quality exam or the highest quality treatment or the highest quality care for the dose that we're giving you, so that we minimize the negative in terms of bad things from the dose, and we emphasize the good things that come from this treatment or exam or whatever. And I would like to avoid the use of Alera, which I like to keep only for occupational doses, and go towards as low as diagnostically achievable or as high quality as achievable, and be positive about it in terms of this is a good thing and that we are maybe finding something that can save your life immediately or even in the near term or even far term.
Yeah, great point. Thank you.
Just a comment and a question about talking with pregnant ladies. And I go back and forth about whether I get into this with them, but I think it's important to keep in the back of your mind in the discussion is that you don't ever get to say never. You don't get to tell them, you know, you don't have anything to worry about, because the next thing you know, the outcome of their pregnancy might be the 4 to 10% of quote normal pregnancies that have something peculiar. And so maybe it's worth saying, you know, this exam is almost no risk, but there is natural risk associated with having babies.
Right.
The second thing is a question triggered by your slide there. It says medical physics consult. In therapy land, if a doctor asks you to consult, you get to bill 77370. Anybody have any experience billing and getting paid by using code 77370 for these kinds of scenarios?
Yeah.
So you mentioned a few times empathy, and I know that, you know, in this setting, I can be a little flippant about, well, that's obvious, just tell the, you know, physician that they're crazy or whatever. But I will share with this because this completely changed how I talk to patients about radiation risk. When my daughter was 7 weeks old, they were concerned that her skull was a funny shape, and so they were concerned about premature sagittal suture fusion, and they ordered a 2-view skull x-ray. And I'm in the room, and I'm holding my 7-week-old daughter for the skull x-ray, and I had this moment of panic. And I'm like, oh my goodness, am I doing the right thing? Am I being irresponsible by allowing them to do this 2-view skull x-ray for my daughter? And I thought, wait a minute, I of all people should not be having this panicked reaction. But it demonstrated to me that there's a very emotional response to some of these things, especially from parents, but also with patients for themselves, that's totally separate from any sort of rational thought. And I think that really changed how I interact with patients, because I know you've said, you know, using units, whatever, that's helpful to some degree, but there's also that emotional side that I think you have to be willing to recognize.
Yeah, that's very true. All right, I think we're actually 3 minutes over time, so thank you very much.